Welcome, everybody, to today's Consortium of Universities for Global Health webinar on preventing blindness, a global health challenge vital to achieving the Sustainable Development Goals. I'm Dr. Keith Martin, the Executive Director of CUGH. All of us rely on our vision for our lives, but it's hard to imagine that over 1 billion people around the world have impaired vision, and 90% of those individuals cannot access existing therapies that would enable them to get their vision back. This is a catastrophic challenge that has been neglected for far too long. And almost everyone will have a need for vision care at some time in their life. And there is going to be an increasing need for this care as the global population ages. But as we know, that care is not universally accessible. There have been, though, some exciting reports that have come out to increase interest and awareness about this global challenge. The Lancet Global Health Commission on Global Eye Health came out recently. There was, of course, the WHO report, the World Vision Report in 2019. So how are we going to address this global challenge? Well, I'm very pleased today to have three global leaders in ophthalmology who are going to share with us what we can do to increase access to vision care around the world. Mr. Peter Holland is the CEO of the International Agency for the Prevention of Blindness in London, UK. Dr. Paul Chan is professor and head of ophthalmology and vision sciences at the Illinois Eye and Ear Infirmary in Chicago. He is also the secretary for the Global Health Alliances at the American Association of Ophthalmology. And Dr. Vivienne Yin is an associate professor at the Division of Oculoplastics and Orbit at the University of British Columbia in Canada. She is also the chair of the Canadian Association for Public Health and Global Ophthalmology. Well, we're really honored and welcome to have these great, outstanding speakers for us here today. We will have questions at the end of their presentations, so please start to put your questions into the question box. And now I'm going to turn it over to Mr. Holland. Peter, welcome, and over to you.
Thank you very much, Keith. Let me just share my screen. So, Keith, thank you very much indeed, and thanks very much for the opportunity to address the consortium today. As you said, I'm Peter Holland. I'm Chief Executive of the International Agency for the Prevention of Blindness. We're essentially the overarching alliance for the global eye care sector. We're a membership organisation. We've got over 150 members worldwide, drawn from non-governmental organisations, corporate organisations, academic and research institutions, eye hospitals, and professional associations. What I want to talk to you about today is really to try to introduce the issue, why eye health matters so much, and some thoughts on how we can begin to bridge that enormous gap in need that Keith mentioned. So as Keith mentioned, there have been two landmark reports in the past couple of years. Firstly, the World Health Organization's World Report on Vision, and secondly, published just last month and launched at the United Nations, the Lancet Global Health Commission on Global Eye Health. And really both reports pointed to the same thing, both the significance of the issue, not just as a healthcare issue, but a much wider development and economic issue, but also some of similar themes in how we can begin to address it. They both, first of all, drew out, and as Keith has already alluded to, the scale of the problem. Over 1 billion people worldwide live with sight loss because they don't have access to basic eye care services. And I think that's a shockingly large number. And of course, that burden of sight loss isn't borne equally. Significantly more women than men have sight loss because they don't have access to eye care. And over 90% of those 1.1 billion people live in lower and middle income countries. And as Keith has said, the problem is potentially growing. Certainly if we continue business as usual, it's growing significantly because of aging population, because of eye health conditions associated with other conditions such as diabetes, and because of the growing epidemic of myopia. By 2050, if we don't do something about it, over half the population of the world will have vision impairment and sight loss associated with that. It's almost 5 billion people. And The impact, of course, goes significantly wider than just simply a health issue. The Lancet report drew really for the first time, drew the evidence together of the much wider impact of sight loss and vision loss across the board. And its really significant impact on achieving the globe's 17 Sustainable Development Goals. And what the Lancet showed was that eye health directly affects 8 of those Sustainable Development Goals. They're up here. I won't talk about all of them, but let me touch on a few. First, in terms of economic productivity, there's good evidence that having good access to glasses can improve workplace productivity from between 20 to 30%. And the Lancet, for the first time, did an economic analysis of the impact of what the vision loss worldwide has on the global economy, and they assessed that at a very conservative estimate, the world loses about $411 billion in lost productivity because of lack of access to eye care. Good eye health obviously has a positive impact on education outcomes. It's estimated it's probably the single most cost-effective intervention for school children, reduces the odds of failing a class by almost 50%. And something that I think people don't immediately consider is that actually good eye health saves lives. But the Lancet have assessed that poor eye health increases mortality by up to 2.6 times. So improving eye health and improving eye care helps reduce poverty, delivers good quality education, decent work, and gender equality. In many ways, it's a golden thread that runs through the Sustainable Development Goals. And of course, we know many of the solutions. They're not complex. Eye tests, glasses, cataract operations, eye care, these are some of the most feasible and cost-effective of all healthcare interventions. And I think in many respects, the simplicity of many of the solutions to the eye care challenge makes that number, the more than billion people who live with sight loss because they don't have access to eye care services, even more shocking. So why? What actually underpins it? Why is there such a big gap? Why is there such a great need for eye care? I would point to four broad areas. Firstly, I'd look at understanding and awareness. And this is both in terms of public awareness, one's own awareness of one's own eye health needs and the needs for eye care services, and sometimes the stigma that comes with sight loss or indeed with wearing glasses. That means that it depresses demand, that people don't demand services because they don't actually aren't necessarily aware that those services exist or that they need them at all. But that then has an impact on decision makers and politicians that translates into, and particularly you see the lack of political awareness and understanding of the sorts of benefits and the sorts of impact, the wider impact that eye health has on the economy and social development. That in turn, I think, leads to a lack of commitment from politicians and policymakers to investing in eye health, and as a result, a funding gap. The World Health Organization has estimated that the cost of covering the gap in eye health services is about $14 billion. That's a significant amount, but in the context, for example, of the money that we spent on tackling COVID, it's not an impossible amount of money. But underpinning that are some of the challenges around systems and people and the resources that go into that. The World Report on Vision identified that one of the very significant problems with eye care services was the lack of integration with mainstream health services. And particularly that eye health is often siloed away and delivered in terms of vertical programs. And they see that lack of integration as one of the really significant problems in terms of expanding access. But a final area, and I think this is something that is pretty unique to eye health in the context of healthcare more broadly, is the wider regulatory and market environment. Many people receive their eye care services through the private sector, and particularly access to glasses is often delivered through the private sector. So critically, you need services being able to deliver widely and crucially affordably. And often regulations that exist can act against that. So for example, if glasses are taxed as a luxury good, it can immediately price them out of the reach of many people who can't afford to buy glasses as if they were a luxury good. At the same time, you need to set up incentives to encourage private sector players to deliver affordable services in accessible places as well. So the World Report on Vision also set out a strategic framework to guide action at a global and regional level. And these were the 5 key recommendations. Firstly, that eye care needs to be made an integral part of universal health coverage. I'll come back to that in a moment. And I'll also talk in a bit more detail about the next recommendation, implementing integrated people-centered eye care in health systems. Its other recommendations focused on promoting high quality research, monitoring trends and evaluation, and then raising awareness and empowering people in the communities. So tackling many of the hurdles that I've identified. Critical to the World Report on Vision was arguing that eye health needed to be included as a core part of universal health coverage, both in national health plans, but also in financing systems and in health insurance. Indeed, they argued very strongly that universal health coverage is not universal if eye care isn't a core part of it. But at the heart of the World Report on Vision is the slightly snappily titled Integrated People-Centered Eye Care. So what that is talking about is really calling for eye care services to be integrated as a core part of mainstream health services. So they're managed and delivered so that people can receive a continuum of eye care services covering promotion, prevention, treatment and rehabilitation, particularly according to their needs. And there was a particular focus on developing primary and community services and the referral pathways between them. So in particular, you can get services close to where people live. That means strengthening a whole load of systems, but critically, it's looking at the people who provide eye care services. And that is a particular challenge. This, I guess, is true for many aspects of healthcare, but there is a particular challenge in many countries, and particularly low and middle income countries, in terms of specialist eye care personnel. And so I think a particular challenge for eye care is to begin to broaden the range of healthcare workers who can deliver eye health services, and focusing much more on the competencies they need rather than just the professional specialisms they have. And that's particularly true at community and primary care level, where you need primary care workers who are able to screen and provide treatments appropriately at that level so that services are provided close to where people live. I think the integration agenda also goes beyond integration into health systems. Actually, for eye care, we need to begin to look beyond health systems and look at working with other sectors as well. So, for example, with the education sector, in terms of integrating screening at as part of school health services, and even with employers. If there's such a clear business case in terms of improving productivity, I think there is a real challenge for us in the eye care sector to persuade employers of actually that it's in their interests to provide support to their employees, to provide good environments to work in, to provide screening, prevention, and access to glasses, for example, in their workplaces, but also for us to work with them on how they can do that. And I think that leads really to my final point, which is that we need to really elevate this issue. We need to engage a much broader range of people in understanding the importance of eye health, and particularly persuade decision makers to unlock the political will and financing to do that. We've already seen progress in that. There are a series of country dialogues managed in over 50 to 60 countries to begin to roll out the World Report on Vision, the recommendations of the World Report on Vision. The Commonwealth has taken significant steps since the last Heads of Government meeting in 2018, where it made a commitment to eye health. The World Health Organization, there's been a resolution following the World Report on Vision on committing countries to implementing its recommendations. And for the first time at the UN, we're hoping that we will get a resolution on vision. It's the first time that vision will have been mentioned at the UN, linking vision very clearly with the implementation of the Sustainable Development Goals. So I think as we emerge from the pandemic, it's really important that we make the case that eye health is a really critical part of building back so that the billion people who don't have access to eye care aren't left behind and do get access to the services they need. I'm going to now hand over to Dr. Paul Chan. Thanks very much.
Sorry, so thank you again. Thanks, Mr. Holland. And very special thanks to Dr. Martin and Dr. Yin for having me here today. I'm going to use ROP as a sort of example, sort of a case example, following up with what Mr. Holland discussed about how this specific condition can provide some insight into the challenges and opportunities that we face around global blindness prevention. And when you look at the Lancet report, they also identified retinopathy prematurity as really one of the emerging threats as we're starting to see more and more of this throughout the world. Here are my financial disclosures. I do want to recognize the support that we've received from USAID and also from the Knights Templar Eye Foundation. And very importantly, I want to acknowledge the incredible group of people that I work with, the large group, to get these international programs off the ground, specifically the Intermediate Informatics for ROP Consortium with Mike Chang, Pete Campbell, Jayshree Kapathy Kramer, Susan Osmo, and Karen Jonas, and all of our international partners who've helped us along the past 10 years. Let's talk a little bit about retinopathy prematurity and why it matters. So when you look at premature births throughout the world, there is an increasing number of premature births, not just in the United States or in the Western countries, but also when you're looking at sub-Saharan Africa as well. And we'll talk a little bit about that. And of those premature babies, there will be a significant number of children at risk for developing this condition, ROP, which then, of course, can lead to severe vision impairment and blindness. Historically speaking, we've faced a number of epidemics around ROP as we increase our neonatal capacity and start to see children do better. So early on, we started to see it in Eastern Europe and Latin America, and then in Southeast Asia. And now, interestingly, when many people felt that it was going to take some time, we're really seeing a significant number of cases of ROP and children going blind in sub-Saharan Africa. So this is a really emerging epidemic here. In terms of what happens to these children, what's interesting is that ROP is not the same everywhere, even though it is a worldwide problem. And in developing countries, we are seeing that children at risk for ROP are actually older and also heavier at birth. So there may be some, and we think there is for sure, some link to how neonatal care is being delivered. So you have more babies at risk, you have higher risk per baby. And one of the main issues also, and this is something that I've been very interested in, is the fact that we have fewer and fewer healthcare providers able to screen and prevent ROP and prevent children from going blind, right? So there's a workforce issue as well. And when you look at what the association is between oxygen management and neonatal care and ROP development, there is truly a link here. So education is paramount in what we're doing. Okay, so just a little overview about ROP, what the problem is, the numbers, what causes it, and the fundamental issues around care. Okay, so we see this as a multidisciplinary approach, right? So not just the ophthalmologist, but also the neonatal team. So the neonatologist, the NICU nurse, also hospital administration and government authorities are very, very important in preventing this from becoming a problem. What I'm going to do now is just share my experience over the past 10 years about program development, what we've encountered, and the programs that I've been involved in. So one of the first programs that I actually participated in was back in 2010 with one of my good friends, Tom Lee, and the Armenian Eye Care Project. And you can see here a number of NICUs from 1995 to 2010 in Armenia. And when we went there, what we initially saw were children who have never been screened for ROP, a number of children who actually had advanced disease and had already gone blind, but no clear protocols. And also, again, this awareness issue about what was causing this condition and how to prevent it. What we did was, utilizing technology, and this is one of the unique aspects of ophthalmology that I think we have a significant opportunity to capitalize on, is that ophthalmology is well suited for digital technology and also innovation. We used digital images. We trained the nurses, the physicians, the retina specialists, the staff, all through digital imaging. We performed telemedicine readings and performed teleeducation. And in really a matter of about 2 to 3 years, they became self-sufficient, right? So they had protocols in place, they had workforce, they had educational programs, and it continues to thrive today. But when you think that this was just about 10 years ago, that there was no screening protocols for these children in this emerging issue, and how you have to go about this multidisciplinary team to combat blindness from retinopathic prematurity. Started to work then with other non-NGOs such as Orbis International. So in 2011, we started to look at what was happening in Southeast Asia. So we went to Mongolia and really try to assess the ROP burden there, identify what the risk was, and develop screening protocols. But again, similar to our experience in Armenia, this was very, very sort of nascent. It's at the beginning of this issue. And this is the type of eye disease that we saw. And you don't have to be an ophthalmologist to look at these images and realize that there's something significant going on here. So on the top, this is a form of ROP that we call aggressive ROP. And this can go very quickly and cause blindness very quickly if not treated in time. And we performed the very first treatments for this condition there. In the bottom panel, you can see here, very, very significant disease. This child is already blind from ROP, and there's really not a lot that we can do with it. And when you think about the conversations that I had at this time, and in this baby in particular in the bottom, parents coming to you asking what could have been done. And what we do know is that if identified early, at least for secondary prevention, this is preventable in terms of blindness. So if we have good screening protocols in place, if we have teamwork and communication in place with the NICU team, we can prevent blindness in these children if we treat it early enough. So in Mongolia, we collaborated with the neonatology team, with the INGO, with nursing, to implement these ROP programs in Mongolia, and also, very importantly, developed support from the government and from the hospital administration to create the infrastructure to manage these children in the long term. And this program continues on today. We also partnered with Helen Keller International in developing telemedicine programs there, and also improving screening capacity with Taganga Institute of Ophthalmology and the folks there looking at different hospitals here in the Kathmandu area. In this case, they use a lower cost camera called the Forest 3 Neonethra. Again, very effective program, continues on today. And what's interesting about this program that's different from the others is that it's starting to use mobile health technology to promote follow-up for parents. So one of the things, again, it's a team approach. It doesn't just involve the healthcare team, but education for families is paramount for preventing blindness from this condition, and making sure that parents have the ability to follow up. And as many of us know, parents may travel significant distances to come for screening. So in order to get them to come in and to make sure that they're aware of it, we have developed very, very unique programs with mHealth and mobile phone technology. And now going further, we're starting to look at the use of artificial intelligence for assisted diagnosis, improving access to care for children in this area. The group at Aravind Eye Hospital in Coimbatore has a very, very well-run program in ROP care. It's called the ROPE-SOS program. This was supported by USAID. You can see here that they're based in Coimbatore, but they screen all around the region to cover a number of NICUs in the area using a mobile van and a digital imaging system. This is Dr. Parag Shah and also Dr. Narendra Venkatapathy, who manage the program and lead the program. Very, very effective. And what we're doing now with them in partnership, this is another unmet need, I think, in eye care in general, is the use of very robust data management tools, right, and also telemedicine reading centers. But what's nice about the Aravind system is that they're starting to look at the use of AI for screening with our partner, Dr. Peter Campbell, who also runs the IROP consortium. Teleeducation has also been something that we've utilized with our international partners. So again, like I mentioned before, ophthalmology is well suited for digital imaging and technology. We can also train and increase capacity and increase our workforce by using these teleeducation platforms similar to this that we developed. We've shown through a number of studies with our international partners that it's very, very effective in improving diagnostic accuracy for these partners and in terms of ROP diagnosis. That's a major issue, especially as we shift towards telemedicine reading. We also subscribe to telementoring. Here's our partner in Mongolia. Again, over the course of many years, we went through these images with them in early morning, our time, evening, their time, to train them how to diagnose ROP more effectively. Utilizing cloud-based platforms with data management, we mentioned that. We built out a system called Intelligent. What this is enabling us to do also is to, again, identify who's at risk for ROP, again, get the data to really understand how the disease is affecting children, and also to potentially improve outcomes. AI is such a hot topic, but again, it has such an important place as we move forward in promoting access to care and also potentially improving health equity in LMICs, especially for ROP care. The IROP DL system that I've been a part of with the IROP consortium recently received breakthrough status by the FDA. We started using it to understand disease in our programs with our international partners. Here, the Nepal program, and what we found was that even with different camera systems, we're finding that the AI system correlates well with disease severity and is actually very good at identifying disease. Most recently, this paper was published with our group in India. And what this is interesting because not only does it show that at the individual eye examination level, the system is good at detecting ROP, but also at the population level, looking at the neonatal intensive care units, the ROP severity was higher in these NICUs that did not have the resources to monitor and titrate oxygen. So you can think about how that could potentially be used to improve primary prevention and improve care. So the results from this paper was a proof of principle that AI may be used to improve the efficiency of ROP screening and also as an epidemiological tool for monitoring NICU level ROP severity across geography and time. And we're using this as well to look at our cases in Nepal and also in Mongolia with our partners. So in summary, when talking about ROP and ROP program development, it's really just an example of some of the opportunities that we have had and also the challenges throughout really a number of eye conditions as well, such as diabetic retinopathy and so forth. But what it stresses is that really to tackle these problems, to be successful, as many of you know, it's a team approach, right? We have strong global partners, but from a technological perspective, we also have seen that many of these countries have adequate internet infrastructure, which then provides us the opportunity to use telemedicine, teleeducation, telesurgery, AI, imaging, and so forth. And as these countries develop further, we're going to start to see more ROP. But again, there are also a number of challenges that we face. How do you make it sustainable? PHI, increasing the workforce, and so forth. Going forward, we are starting to see an increasing number of children at risk for ROP in sub-Saharan Africa. So again, this growing third epidemic. But what we're focused on is primary prevention and also prevention of ROP in general and keeping these kids from going blind. Ophthalmology, again, is unique and has certain advantages in technology for improving access to care. And I think very important, we need to stress the issues around advocacy and strong partnerships to train global leaders. So I do a lot of work with the American Academy of Ophthalmology. One of the initiatives is around training leaders and partnering with national and supranational societies around leadership development and advocacy. And that's a critical piece for ROP program development. So you see here on the right, obviously it's a multidisciplinary approach here, regarding research, mentoring, education, advocacy, ultimately collaboration among all stakeholders. So I appreciate the opportunity to speak here to you today. And at this point, I'm going to pass it off to Dr. Yin. Again, thank you very much.
Thank you, Dr. Chen. That was incredible. And I love how you highlighted one disease, but really talked about multiple components of what's needed for us as an eye health community globally. And thank you, Dr. Keith Martin, for putting together another stellar webinar and panel for CUGH. My name is Dr. Vivian Yin. I am an ophthalmologist and oculoplastic surgeon in Vancouver, Canada. I'm also the chair of the Canadian Association for Public Health and Global Ophthalmology. You've heard from the other speakers already on the issue and the magnitude of visual impairment and blindness globally. And of course, we know that this is unevenly distributed towards low and middle income countries. Now, why do we care? And I always try to remind myself whenever things get tough, that this is a picture that we don't ever want to see again, which is a child that is bilaterally blind from a congenital disease, congenital cataracts, yet we couldn't reach her in order to make her see again. But you see her earring there that is a Coke bottle. So if Coca-Cola and fast food and these companies can reach these individuals, why couldn't we? And I think that brings to the next point that, well, what are the things that have we tried in the past? And I'm going to talk a little bit more on a community-based and a more public health-based approach to addressing blindness and preventable blindness specifically. So traditionally, we have tried to tackle this through outreach programs, in the traditional sense of teams going out. And then the other thing that readily come to mind that was highlighted earlier by Mr. Peter Holland was the issues of cost. So when we try to do that by sending out outreach team for screening and treatment or providing care for free, what we found was that we were able to increase care and access to these individuals that were otherwise hard to reach, but it wasn't significant. It was a slight nudge towards the positive. So that begs the question, how can we really scale this up, recognizing how big this problem really is? Through decades of research, we now know a lot better in terms of what is really the barriers for people to access treatment for eye health. It wasn't just the cost of the surgery themselves, but it was also cost, both direct and indirect, of the travel to the hospital, as well as you have to imagine the cost of having a companion to travel that long distance with them. A lot of times, as highlighted by previous speakers, people are unaware of the available treatment and that it is even treatable. And then there's the fear of the unknown, the fear of what is these surgeries, these treatment that we're trying to promote and get them to undergo. And lastly, in a lot of these countries, people feel that once you reach a certain age, that it really makes no difference in trying to regain their quality of life or regain their productivity in society. So from a community base, Dr. Chan has mentioned this as well as Mr. Holland, that we really need to get the care to the people instead of trying to set up massive center that people can't get to. And this is where vision centers or community eye centers comes into play. These are manned centers that are permanent structures with usually a what's called a mid-level ophthalmic technician that is capable of simple diagnostic, but more importantly, very, very capable in assessment of disease. And previously mentioned, the use of technology is uniquely positioned in eye care because of such a visually based or image-based specialty. Now, these center provides permanent care every single day for their local community, and they're oftentimes manned by people within the community. So girls and women that are members of this community are the one that are providing care for their neighbors, for their relatives. And we see that we're able to make this as widely distributed throughout the country. And this example comes from India, out of the network of Aravind Eye Hospital. And the vision then was really to make eye health services as prevalent as McDonald's. Now, at first, this might seem like a strange comparison, comparing eye health to fast food chain, but the idea is that you want something so easily and readily accessible that people will use these services. What about elsewhere? Can we replicate this model? And we've seen that this is the network of eye health services by Save a Canada network, and that we are able to do this in other countries in order to make sure that in every country we can reach all the different regions and not have health services centered around urban centers only. Now, the story continues into East and West Africa, and we are seeing a slightly different model or a switch of gear. Now, in East and West Africa, the problem we face is that population is not as dense. So the model we've used in Southeast Asia doesn't quite work as well. But another interesting thing that we've discovered now is the ability for these centers called Vision Center in Asia, but in Africa called Community Eye Center, and their ability to be sustainable and independent after an initial investment. With $50,000, you're able to open a brand new center, and after 2 or 3 years, these centers are fully self-sustaining, using their own revenue generated from sales of glasses, sales of medication. And of course, this is on a scale model where if you can pay more, you pay more, but if you can't pay, the service is still provided for free. We've heard earlier from other speakers the issues of equity and specifically gender equity when it comes to eye health. Majority of women are still the ones that are blind based on our statistic. And this is true both in Asia and Africa, and not having a really regional predilection. Even though we know that women are not more likely to get the disease, so this gender predominance is really not based on a biological framework, but rather based because of cultural and local beliefs that women may be less valuable to society, therefore less likely to seek care. But it also has the overlay of the fact that when you have to travel in a lot of these countries, it is not safe for women to travel alone or travel long distances. Therefore, it makes it much harder for them to access care. And this is where I think tapping into local talents or this concept of people-integrated or people-centered integrated care is really driving at. What we've seen in Southeast Asia is the utilization of female community health volunteers, which are community workers that are already built within the country's healthcare system or public health system. These women are usually mothers or sisters that lives within the villages that are educated. They are not formally trained in healthcare system, but they're trained specifically for health education, for administration immunization, for administration of simple medications such as vitamin A. And these have been highly effective in decreasing childhood morbidity and mortality And for us tapping into this network, what we've been able to achieve is using this already established network to help educate local villagers on the available treatment for blinding conditions. Similarly, in other countries in Sub-Saharan Africa, there may not be country-specific community health worker, but there are other groups that we can think about, such as the microfinancing groups in East and West Africa. These are organizations that already existed of groups of women trying to make an income through crafts or other skill set, and they have already identified leaders among themselves that lead these groups. By tapping into these already formalized community or village-based organizations, we're able to leverage what's already existed in terms of their social network and certainly in terms of the trust that they already have with their local community in order to disseminate in a large fashion both education but also screening for blinding disease, that if we catch them early, like the condition that Dr. Chen has mentioned, that we can effectively prevent a blindness that is going to impact this child or this community for life. So what's the evidence behind some of these interventions I've talked about in terms of tapping into local talents and local existing infrastructure? We've seen that both in Sub-Saharan Africa as well as Southeast Asia, that we're now starting to see a bigger increase in terms of the magnitude that we're able to achieve for both gender-specific impact, with now more women being treated than men, playing the catch-up game, of course, of decades of gender inequity, but also that we're starting to see overall both male and female in terms of cataract surgical coverage, as well as acceptance and attendance to care. Now, in terms of children and childhood blindness, this has always been a part that is the hardest to reach. Some of the intervention you've heard earlier in terms of partnering with schools, with teacher training, as well as the network that Dr. Chen talked about integrating into other healthcare programs. By utilizing some of these community health workers as key informants, we've shown that they are much more effective because they know their community so much better than everyone else in identifying children with blindness, and they become the conduit in terms of that bridge mentioned earlier to the healthcare system. And they've been so much more effective in finding children who are blind than our formal health worker, where we think about a traditional, trained social worker or even nurse, and sending them out into the community has not been as effective as these key informants. However, we haven't been able to equalize the gender inequity in childhood blindness, and unfortunately this is an area that I really feel passionate that we have to address, is that 60% of surgery in almost all settings are still performed on boys over girls. So what makes these community interventions so much more successful than the traditional model is really their motivation to help their own communities, and that they're embedded within these communities. They are part of these communities, so they know all the villagers, all the dynamics, all the politics that need to be navigated, and that they are the ones that see these patients that we're trying to help day in, day out. And because they are part of these communities, they live there full time, there's been much better retention of talent when we train them, and much lower turnover or burned out. Well, something like this, how much does it cost when we're talking about scaling up as much as fast food or soda industry? They're actually magnitudes of 10 to 100-fold cheaper than formal healthcare worker. I want to end on a note about research. You sort of gotten a hint through all of our presentations that research has been a key aspect that drives what we do in the intervention we plan. But really, I would say this explosion of evidence-based program planning started really in 2006 when we discovered that we can have a mechanism for rapidly assessing what the magnitude of blindness is through a novel way. So instead of traditional epidemiological study, which takes 2 to 3 years to conduct and very, very costly and health resource-wise draining, we figured out that majority of blindness is an adult who are 50 years and older. And by creating a random sampling and a robust method of assessing this, we've been able to really base things on evidence and base all of our program in a rapid PDSA cycle to make sure that we're able to scale up programs and resources where it's most needed. Now, of course, having us from the West to try to fix problem of the global South is something that we now know is not sustainable and not the future of really getting health access to everyone. So not only do we have to rapidly test what we do, we also have to teach the local faculty. And this is something that is the second area I really wish for more partnership with the entire global health network that CUGH has, which is evidence-based programming and building up operational research capacity in country so that they can really look at their own data, look at their own intervention, and then be able to help their own program continue to improve both on quality as well as on magnitude. So in summary, I think we are able to show some example and successes, but also areas that we need to really scale up and also branch out to able to create an accessible but also acceptable eye care that comes from within these communities. And of course, equity of care is a huge issue, and we have heard that not only is an issue in low and middle income country, but we see magnitude of this also within even developed country. And I think building networks that are within these communities, such as using female community workers to access and address gender equity, is the most effective way. And lastly, of course, we need to make sure that we have the research capacity to drive these local quality assurance and local evidence-based programming in order to reach those that are most difficult to access eye care programs. Thank you very much again for everyone for your opportunity for us to bring this eye health problem to your attention, and I really look forward to more collaboration with the broader community. Thank you, and I'll hand the mic back to Dr. Martin.
Thank you very much, Dr. Yin and Dr. Chen and Mr. Holland. Those were excellent presentations, and you've really laid out the challenge for all of us in the global health community to support what you're doing. So I'm going to take a little bit of license before I get into the questions that are coming in, and please continue to send your questions into the audience. To each of you, what is the one thing that you can share with the global health audience that they can do to be most supportive of what you're doing to reduce blindness? And I'll start maybe Vivian with you, and then we'll go backwards to Dr. Chan and Mr. Holland. Dr. Yin?
Thank you, Keith. I think that's a great question, and I think that's what we're all here today for, which is building a partnership beyond just the eye health community. Like Mr. Holland had mentioned earlier, we've been a bit in a silo in eye health because of what we do being so unique that we have been able to do a lot of our early works on our own. But I think we've reached a point where what we really need to look to in order to reach that 1 billion people is to partner with other organizations beyond eye health, partner with public health agencies, partner with technology companies to scale up some of these technology efforts that we're trying to utilize to reach the most unreachable, and also partner with other health system, the maternity and child health network that's already built in many of these low and middle income countries.
Yeah, so I think that I'm going to agree, and everything that Vivian said is right on. I think that in all the talks today, it stressed the idea of partnerships, right, and collaboration, and just making sure that we have an understanding that we want to partner, and that eye health affects overall systemic health. And Mr. Holland, gave a wonderful overview about how eye health affects mortality, and for us specifically, for the retinopathy maturity community, we know for a fact that these children who are go blind from ROP live half the life expectancy of someone who can see. So I think partnerships are critical to everything that we're doing, and I think that's the most important thing that we would want help with.
I'm going to be a stuck record on this and echo that. I think, I mean, I guess what would I ask for? I'd ask you to be our allies, allies in making the case, allies in gathering the evidence. And I think also, I guess I'd ask you to think about, are there ways to incorporate and think about sight loss in the work that you do? We're partnering with a business school on looking at using iHealth as a case study in terms of designing new business models for social enterprise and private sector organisations to deliver eye care services affordably through the market. And so thinking perhaps innovatively like that, are there opportunities where you can incorporate iHealth issues into the work that you do as well?
Thank you so much. Those are, you definitely have an ally here at CUGH, and your guidance is very valuable. A question from an ophthalmologist with 24 years of clinical experience and is in the United States, but if you could respond to the question for an ophthalmologist anywhere in the world. The question really this individual is asking is, how can they get involved in global ophthalmology, and how can they work and support the work that you're doing? Who would like to take that?
Shall I kick off from IPB? So IPB, we're a membership organisation. So the best way would be for your organisation to join us. We're, as I say, we have members really across the sector. So local hospitals, academic institutions, local NGOs. So if your organisation wanted to join us, we'd be delighted. We'd be delighted to have you. And then we have a range of working groups and meetings, and now a lot of online meetings, which provide opportunities for you to engage with us.
Yeah, maybe I'll take that from an American Academy of Ophthalmology perspective, Dr. Martin. So if you're in the United States and you are a member of the Academy, there are a number of programs that you can get involved with that focus on global ophthalmology specifically. You know, one of the things that I think we didn't discuss also is just that, you know, there's always this expression that globally starts locally, right? And I think that looking at the need in our own communities, you know, for example, here in Chicago on the West Side, right, the number of patients who actually need our care, and also the Indian Health Services, you know, that also, you know, a lot of issues around access and so forth. But I think from an AAO perspective, you know, reach out to us, you know, for the global alliances. We also have a new task force on academic global ophthalmology that is also addressing that specific question around, you know, how can our membership and how can, you know, which is 25% international as well, get more involved and add value to to this discussion.
So I think I'll finish up and answer that from a slightly different perspective. I also work extensively with NGOs. I'm on the board chair of Save Canada. And I would say that one of the biggest thing I've seen over the past 10 years that allow anyone with interest in global health to become really involved has been drive and passion and commitment. So I would say if you are an ophthalmologist anywhere in the world that has a passion of wanting to help this fight and help, you know, join the community, it's a matter of linking up with existing organization. It can be accessing from association perspective, as Dr. Chen mentioned, or even accessing some of the NGOs that you saw that Dr. Holland, Mr. Holland had shown on his slides. There's these NGOs has been working, you know, for 30, 40, 50 years in many of these countries. And really, I would say the one advice I would tell young ophthalmologists, which I get this question a lot, is tap into already existing network. You know, there are a lot of issues we didn't talk about in our presentations. We were having an offline chat about with Dr. Martin earlier, which is the issue of supply chain. There's more issues that you can realize that we can't highlight in a 1-hour webinar. So instead of recreating, you know, instead of recreating everything again, there's a lot of experience in the field, and it's a matter of partnership and leveraging everyone's expertise in the specific area.
I'm going to ask a question to each of you because we're running low on time, and then we'll get to a wrap up. So, Dr. Chan, this individual wants to know how they can, Annika wants to know if there are any partnerships to tackle ROP prevention in sub-Saharan Africa. And many people would like to know how they can contact all of you. So maybe in your closing comments, you can share how they can do that. The second question, also to Dr. Chan, it'll go to you, is a pediatrician working with Baylor in Argentina. Actually, you let them know how to contact you, that will answer that question. Dr. Yin, as a recent graduate though in public health, interested in health systems, how can they get involved in the eye health space? And Mr. Holland, to you, Francophone Africa comes from Nicole Bouali, wants to know that Francophone Africa is far behind screening and treatment, and how can individuals in Francophone Africa get involved in scaling up the programs you're talking about? So maybe I'll ask you first, Dr. Chan, then Dr. Yin, and then Mr. Holland.
Great, thanks, Dr. Martin. So to the first question, which was about what specific activities or programs are there that are looking at how to address the ROP issues in Africa or sub-Saharan Africa?
Correct, yes.
So there are many. The ones that I'm involved in specifically are sponsored by the International Pediatric Ophthalmology and Strabismus Council, which is a program. Many years ago, we started a task force that looked at ROP in sub-Saharan Africa with our partners there. It's then transitioned into a group called Stop Infant Blindness in Africa, or SIBA-CIBA, which is also part of IPOS. So that's an organization that you can access. Claire Gilbert also has done a lot of work with partnerships in India, promoting education for programs in Africa as well. So that these efforts are underway. You know, it's at the very beginning. So if you're interested, you can get involved with it. You know, happy to talk to you more. The pediatrician, I guess, was there a specific question or?
How they contact everybody. So,
Sure.
yeah, well, I think we'll maybe at the end in your closing comments, you can let people know how they can contact you.
Yeah, you can, or email. Okay, great. Thank you.
Thank you very much. Peter, do you want to go ahead, and then Dr. Yin?
Sure, sorry. Yes, I mean, I think it is correct that Francophone Africa does lag behind. We have been doing work, firstly with the World Health Organization in Africa, particularly looking at support around the development of eye health as part of primary care, and to develop resources and materials in French as well as English, so that they can be rolled out in Francophone Africa too. And we're looking to work, and particularly in terms of working with the World Health Organization on rolling out the recommendations of the World Report on Vision across Africa, including obviously in countries in Francophone Africa. We would really welcome the connection, actually, because we do have fewer connections in Francophone Africa. We have a regional coordinator in Africa. So if you email me, or you can contact us through our website, which is iapb.org, I'll be very happy to make the connection.
Thank you, Mr. Holland. Dr. Yin, please.
So I think the question was asking from a recent graph from a Master of Public Health program, how can you get involved with specifically eye health? And I will kind of echo what two other speaker has mentioned. We're always reachable, so definitely you're welcome to reach out to me, and we'll put you in contact into the network of people that are doing things that you're interested in. But more specifically, I would say from a public health standpoint, you know, we do need more of you and more of us. The magnitude that we need in terms of clinicians don't always understand how public health and health systems work. I think, Dr. Chan's an exception. And I think we need more partnership directly between clinician and public health experts in order to build up that infrastructure and to help with evidence-driven, so therefore research into health system interventions. And I think definitely there's a lot more room for growth in that area.
Thank you very much, Dr. Yin. And now we're going to close. Thank you, everybody, for the great questions. And we're going to close with just some closing comments from our outstanding speakers today. And we'll go in the reverse order with Dr. Yin, Dr. Chan, and then finally Mr. Holland for any closing comments. Please, Dr. Yin.
Thank you, Keith. I would say, partnership and collaboration kind of ring through the entire session. And I would just stress that it is really partnership beyond just the eye health communities, and it's partnership on all levels, partnership in research, partnership in service delivery. We even talked a little bit of partnership with market and with companies, as well as partnership with government organization. And I would say, we really need to look at this from a health holistic approach rather than thinking this is just eye health, and the impact that you're going to make in this individual goes beyond just being able to see it. Goes beyond, it goes to poverty, addressing education, and I really welcome anyone on this webinar to join the fight against blindness.
Thank you, Dr. Yin. Dr. Chan.
I agree with all of the above, as I mentioned, but I will add one thing. So I mentioned the issues around innovation. So I think that ophthalmology and eye health in general, we are, we love technology, and I think that the conditions that we treat are very, very appropriate in terms of addressing these issues around utilizing new technology and low-cost technology. So I think that those partnerships are also very critical for us. So, happy to discuss those things more, but I think for us, a lot of our increased access is going to depend on these partnerships with industry, with engineering, and other disciplines, as well as healthcare.
Thank you, Dr. Chan. Please, Mr. Holland.
Thank you. Thanks very much, Keith, and thank you very much. It's been fantastic to share a panel with Dr. Chan and Dr. Yin, as well as yourself. So just to repeat, you can find us at iapb.org, and you can contact us through that or email me directly, and that would be great. And I mean, I would just, I guess, repeat that the scale of the challenge is enormous. It's 1 billion, it's over 1 billion people. But at the same time, we know what to do. Most of the sorts of interventions we're talking about, these are not complex interventions for the vast majority of people we're talking about. So really the challenge for us is the challenge that we've set out. It's around integrating what we do, and that's a challenge, I think, for the eye care sector. And critically echoing what Dr. Chan and Dr. Yin have just said, that we need to work in partnership. And that's why it's been a great opportunity to talk to everybody through this consortium, because I think it's really important for us as a sector to reach out and work with people across a whole range of sectors that we've heard, if we're really going to succeed over the next decade. Thanks very much.
Well, that was fantastic. On behalf of all of us at CUGH, I'd like to thank Dr. Vivian Yin, Dr. Paul Chan, and Mr. Peter Holland for your excellent presentations. You've really laid out with clarity the challenge before us, and also the opportunity to be able to address this issue, which is a medical issue, it's a public health issue, but it's also a humanitarian issue. And I think it would be impossible for anybody to look at the slides you've seen for the little girl who's blind, or the child with retinopathy of prematurity who will never see again, and to just think for yourself if that was your child or if that was you. And I think you've all laid out that this is low-hanging fruit, it's doable, we know what to do, we know who's affected, and we need to partner to be able to address this immense, neglected, and solvable global health challenge. And at CUGH, we will partner with you to achieve that goal. So thank you, everybody, for listening today. This webinar will be on CUGH's website in several days. And we look forward to seeing you next time. And again, on behalf of all of us, thank you so much to our fabulous speakers today on this very important webinar. Have a wonderful day, everybody.